morning, friends. Welcome to Dr. PM Times. This is Dr. Murugesan. In this episode, I am going to discuss about the physiology of insulin secretion, because the knowledge of the way in which insulin is secreted, how it is released, will be very, very helpful in treating especially an insulin-dependent diabetic. So you should know the basis, or then only you will be able to treat it or understand about this powerful hormone insulin. Insulin is a very, very powerful hormone. It is secreted by the endocrine part of pancreas. The tail portion of pancreas contains an island of cells called islets of Langerhans. There are three major cells in the islands of Langerhans, namely the beta cells, alpha cells, and delta cells. And it is the beta cells of islets of Langerhans that secrete this important hormone called insulin. The insulin is released in response to an oral glucose load with the help of incretins secreted from the proximal small intestine, that is duodenum, which I have already told you, GLP-1 and GAP. This acts on the beta cells and stimulates the release of insulin. The insulin that is released is mostly 90% of insulin secreted from a normal beta cell. A person, a normal adult, a healthy adult, 90% of secretions of beta cells are mature insulin. That means there is also immature insulin secretion. So insulin is secreted in stages. First, it is secreted as pre-proinsulin, then it is cleaved to form proinsulin, and then finally it comes out of beta cells as mature insulin. The two precursors, pre-proinsulin and proinsulin, are immature insulin. The important thing to be noted here is it is the mature insulin which has got its all physiological functions, whereas pre-proinsulin and proinsulin are not physiologically as powerful as a mature insulin. Why it is important? Because in a long-standing diabetic, say for example, a person who is diabetic for 10 years, a 40-year-old diagnosed as diabetes, he must be having diabetes for the past 10 years, pre-diabetes, then becomes an established diabetes. And he starts losing the beta cells gradually. And if he's put on oral hypoglycemic agents, say sulfonylureas, what these drugs do is they squeeze the remaining beta cell and release the insulin, whatever is left over. This cannot go on forever. Gradually, they start losing the beta cell further. Also, because they squeeze or flog already tired horse, that is exhausted beta cell, the beta cell starts releasing more of immature or precursors, pre-proinsulin and proinsulin, which are not physiologically active. So that is why we diabetologists advise them not to take sulfonylureas for a longer duration, because though the insulin secretion may be normal, the power of the insulin that is secreted or the nature of the insulin that is secreted may not be as efficient as a mature insulin. It is mostly pro-insulin. So this point we should know before putting any patient on sulfonylureas, or before any patient keeps on taking sulfonylureas, glimepiride, glycoside, etc. They should remember that the drug that they are taking in the long run may become harmful for them. Then the insulin that is released as mature insulin is usually released in pulses. The normal rate of insulin secretion is 1 international unit per hour, or at the maximum of 40 international units per day, and it is released in pulses which can peak after a food intake, which is called prandial insulin secretion. The idea of lifestyle modification advised to the patient is to decrease this prandial surges as much as possible. The insulin released by the pancreas should be smooth and uniform, and it should not be irregular up and down. Don't fast and take a bulky meal afterwards. Don't eat full stomach. Once you eat a full stomach, there will be a rapid surge. Don't take foods which have high glycemic index, say a Mysore pa or any other sweet. If you take, then there will be a sudden surge in the release of insulin, and the beta cells may get confused and the exhaustion is activated. It's more after that. Instead, you advise them to have small frequent meals with low glycemic index with more of fiber intake, so that the stimulation and the release of insulin is uniform. It is a smooth curve. It is not up and down zigzag, which is very much essential to have a normal blood glucose level. And this insulin that is released, as I said, 40 units per day, 20 units of which is used to maintain normal glycemia, basal normoglycemia. when the person is not taking any food, he is just resting, the basal normoglycemia 20 units are utilized. The rest 20 units are used during prandial peaks. So this you should have it in mind while giving insulin. You should give a basal analog which acts for a long time, and the insulins which are short acting, otherwise called prandial insulin, which can act for a short time immediately after every meals. If a person is supposed to take 3 important meals, breakfast, lunch and dinner, then the insulin that is released circulates unbound in the plasma. It is not bound to plasma protein, circulates freely before it goes to the liver and gets metabolized. Because it is not bound to plasma proteins, it is metabolized easily and quickly. The half-life is only 5 minutes. That is why I said insulin is a powerful hormone. So this point you should have it in mind while giving insulin to a patient, because the patient should be advised to have food 10 minutes immediately after having insulin. You should not skip his meals. Then the dose should be appropriate, otherwise the chances of hypoglycemia is very high, which is even more dreaded than hyperglycemic symptoms. So you should remember the half-life of insulin is only 5 to 6 minutes. So give the dosage accordingly. Advise the patient to take food immediately or 10 minutes after taking insulin. Then this insulin goes to the liver, which is the site of energy metabolism. The insulin released by the pancreatic beta cell reaches the pancreatic vein. Through the portal vein, it reaches the liver. So the insulin acts exactly where it is required. As I said, liver is the site of metabolism. It is the place where the insulin glucagon has to have its maximum action. So after going through the metabolic activity in liver, almost half of the insulin that is secreted is metabolized. This is called first pass effect. Only the remaining 50% of insulin reaches the peripheral circulation. This point is important because to diagnose any other endocrine disorders apart from diabetes, what we do to diagnose a thyroid disorder, we do a thyroid hormone bioassay. To assess pituitary disorder, so growth disorders, we do a growth hormone bioassay. But to diagnose diabetes, which is due to an endocrine deficiency of insulin, we don't do an insulin bioassay, because what amount of insulin present in the peripheral circulation is only 50% of what that is secreted. The rest 50% reaches circulation. So there is no point in doing an insulin bioassay to diagnose the diabetic. That is why we do a fasting blood glucose level, postprandial blood glucose level, and HbA1c. But there is another marker called C-peptide, which is released in equimolar concentration along with insulin from the beta cells of islets of Langerhans. So this C-peptide bioassay may be helpful to assess the beta cell function instead of an insulin bioassay. And this insulin that is reaching the peripheral circulation will act on the target organs, mainly the muscle, the liver and adipose tissue. It acts via a type of receptor called GLUT4, which is a gate which is opened. Insulin is the key that unlocks the GLUT4 lock that is present in the cell membrane of the muscle, which allows the entry of glucose into the muscle cells or the liver or adipocytes. And this glucose is utilized as a fuel or energy for our various physiological activities, which brings the blood sugar level under control. So this knowledge of the pattern of insulin release, the stages of insulin release, the fact that it's not bound to plasma proteins, the fact that it has got an excellent first pass effect is very, very essential in understanding the problems faced by a diabetic and in understanding the dosage and duration and the time of insulin to be administered to the patient. Thank you.